Hola, Noel Vargo doing my newborn assessment with the help of my daughter's little friend here. She does have some joint issues, so and she doesn't bend at the knees. So when I go to do the Barlow and orthopnea test, or not orthopnea test, she doesn't bend too well at the knees. So gonna have that issue with her. Before I get started, I'm gonna look at the patient's chart, the mother's chart and the baby's chart, see if check RH status of the mother, any issues during pregnancy, medications, medical problems, allergies, if the mother is a known abuser of substances. Might the patient be lethargic when we walk in because, it passes across the placental membrane and, kids come out not so hot. So, check all that. Knock on the door, open the door, close the door behind myself, do all the preliminary preliminary things that we're supposed to do. Definitely introduce ourselves, maintain privacy and dignity of the patient and the family. Sorry, it's on the bed. This is the quietest room in the house right now because the kids are running around. So, birth history, and then we take vitals. I don't do them right up front. I do them as I go along in my assessments. So, like the temperature probably would be the only one that's done out of anything because it's not a part of any assessment. So, do it axillary or whatever the policy procedure is for that facility, whether it's just inside the rectum or here or wherever. It should be about 36.5 to 37.5. So, and the rest of the vitals, heart rate should be between 110 and 160. Respiratory rate should be between 30 and 60. But that'll come along when we get to the chest assessment. Weight in kilos everything is documented in kilos. Parents like it in standard, so they can say patient was 8 pounds 7 ounces. So have to do it in both kilos for us and standard for family. Length, width, all that lovely stuff. So looking at my patient, I'm going to get a general impression of the patient. Are they breathing too fast, too slow? They have peripheral cyanosis or central cyanosis. My general impression of the patient. Does something need to be done differently right now, like something emergent? So, I'm going to walk up, and one of the tests that can be done right away is the Moro test, the startle test. I accidentally did it to my son when he was born. I bumped the bassinet, and he went, whoa, whoa! And I'm like, there's your startle test. Okay. So if I just happen to bump the bassinet and it happens, then, well, there's my Moro testing. If not, I'll do the Moro test when I'm doing my assessment. So looking at the patient, looking at the skin, all over the patient, we're going to be assessing for skin conditions, fronts of leg, back, chest, the whole 9 yards. We're looking for vernix, malia, laningo, the baby hair, and Mongolian spots and petechiae. They all have different things that they mean and need to be documented. So we're going to look for all that while we're going through. Walking up, see the patient, and check the head, make sure it's symmetrical, nothing's out of place, 2 ears, 2 eyes, a nose with 2 nostrils, a mouth. Mouth is symmetrical, check the head, checking for capitate and cephalohematoma. Looking for that, checking the ears, make sure they're equal, line up with the eyes. There's nothing inside, and there's a nice little cartilage area there. Checking for the nose because they're predominantly nose breathers. Checking the eyes, they should be slate gray most of the time. Checking the pupils, pupil and reactive to light. There might be some strabismus, got it right this time. A lazy eye can happen. Conjunctivitis, conjunctiva. So we're going to check the conjunctivas for conjunctivitis, which can happen during birth. Ears, shape, size, did the ears, check the neck, checking for irregularity, deformities, anything like that. Checking the clavicles because they can break a clavicle coming out during natural childbirth. I'm going to look at the extremities, see if there's good muscle tone, good range of motion. If it's an active child, we should see it, the child moving around, and then we'll move their arms and things like that. I'll just move the arms like this, check for deformities because bones do break on occasion. So, you know, check for deformities, make sure they have all their fingers and toes. She's kind of missing one here. So we would document that. Patient has 4 fingers on her right hand. So go along with that. Do my visual assessment of the chest and the abdomen. Make sure I don't see any irregularities, abnormalities, skin condition, like all the vernix and laguna. Laguna we would see up here. Petechiae, all that lovely stuff. And then that will be assessed across the whole patient. And then after I looked at everything, stethoscope goes in, and then we're going to listen to lung sounds. More than likely going to hear wet lung sounds because they've been, you know, in 9 months floating around fluid. So listen to lung sounds. Going to do a minute, should be 30 to 60. I would do the minute, but I want to. And then we're going to listen to the heart sounds for an apical pulse. So I'm going to listen for a murmur and heart sounds at the same time. Murmur and then apical pulse, 1 minute. Click, 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 click. It should be between 110 and 160. Anything less than 100 on an infant, you need to initiate the neonatal resuscitation protocols. I think it's anything less than 100, we start oxygen, and we'll go with that elsewhere. And then go down and listen to the abdomen. We should have active bowel sounds, should hear them. And then listen for any abnormalities. And then do a little palpation of the abdomen, palpation of the chest, looking at the nipples, make sure there's two size. She should be between 2 and 5 millimeters, engorgement, anything like that. Get down to the genitalia, female, spread it, look for labia majora, labia minora, make sure it looks like it's supposed to look, like there's no deformities or discharges. Male, make sure the meatus is centrally located like it's supposed to be, everything's smooth, good. Do not pull the foreskin back. Feel the scrotum, look at rugae on the boy's genitalia, feel scrotum, see if the testes dropped. And then from there, lower extremity, range of motion, checking, going to do the Barlow test, bend it, excuse me, I'm going to deform my daughter's style here. Bend the knees, push up to the chest, and then off to the side for the orthopney test. Off to the side, both legs, checking for hip problems, hip dysplasia, feeling for any deformities, resistance, or clicks. If we hit resistance, we're going to stop. I mean, if we feel anything abnormal, we're going to document and pass it on to providers. Got this done. I'm going to come back up here to the mouth. Gonna stroke across the face, see if the child does some rooting for me. Open the mouth, look at the mouth, see if it's symmetrical. Gonna check for Epstein pearls. No Epstein pearls. Palpate the gums and the tongue and the gums and the hard palate and the soft palate, looking for cleft palate. Palpate the gums, and while I'm in there, I'm going to check for sucking reflex. Got it. While we're here, we're going to turn the child's head like this, and they should do the tonic neck. Turn your head like this. Kid will go into a fencing pose, like so, and then turn the head this way, and it'll be arm out. Look like Bill and Ted. Excellent adventure. So tonic test, sucking test, Moro test. What was the bump the bassinet or kind of bring them up, and the kid should what startle. While we have the hands, we'll check for a palmar response, and then a plantar's response. Did rooting, sucking, or Babinski. Toe should flare. And then we're going to turn the child over, check the back. Check the back for deformities, irregularities, make sure everything is in alignment. There's no holes for spinal bifida. Get down to the buttocks. Gonna swipe our finger across the anus. It should pucker. We should see if that works. Check for fissures, any irregularities and abnormalities. Might even get a response to get some poop coming. And then, pick the child up, do the stepping test. They should pick their feet up when they put the child down. And at that point, I think, wrap the kid up, put the hat back on, ask if mom wants the baby, or if they want to put the baby back and go to, back to the nursery. Check all that, and anything else I can do, and I'm going to note, child's behavior when I go in. Were they sleeping deep? And I was doing everything, and they were sleeping stuffed doll. Was it a light sleep? Were they drowsy? Or was the kid alert but quiet, alert and very active? Was the kid intensely crying? So I will document what I find, but I'll also, document what the parents say, because I'm like, wow, you came in and, she's all over the place. She's been sleeping the whole time. So, parents state child was doing this, but when I came in, child was doing that. So it's all, make sure it all gets documented. And like I said, do what I can to help the family to, get comfortable again. Would you like to hold the child? Child in the bassinet here, child in the bassinet down in the nursery. Do they need a break? Mom might need a break. Mom might need a shower. So, and then that's the end of my assessment. Okay, thanks.